Let me get the right one up here first. Is everybody able to see that?
Yeah, yes.
Okay. All right.
All right. Can everyone hear me okay too, I hope? Okay, great. So like I said, my name is Jess and I'm the ID physician with OPAT. And what I'll start with today are two cases that are very general to what we kind of deal with in the outpatient setting, which is where most of my focus is, taking care of patients who have left Ruby on IV antibiotics and now are being monitored with our program. So this patient, kind of going down our case presentation. So she's a 72-year-old female. The infection type was bone and joint. And proposed antibiotics were dapto and ceftriaxone. Her brief history was that she had come in with some back pain, left lower extremity weakness, just not feeling well. Had actually been transferred into Ruby from an outside facility and was diagnosed with thoracic discitis, osteomyelitis, and an epidural abscess. Infectious disease saw the patient, all cultures were reviewed. She was initially started on vancomycin and ceftriaxone inpatient. And this is where our first OPAT intervention came in, which was we requested her to be adjusted to daptomycin and ceftriaxone. What you can see in terms of her past medical history, so she had a port, was treated for colon cancer and on Xeloda, hypertension, hyperlipidemia, obesity, past DVTs, as well as some anxiety and depression. While in the hospital, when we had gotten the initial OPAT consult, so trying to tee the patient up for discharge, on review, she had come in with an AKI, given some other risk factors for vanc nephrotoxicity in the outpatient setting, including her obesity, age. That's when we had recommended the switch to daptomycin. At discharge, she was actually sent to an acute rehab facility. And it was there that on just routine labs, her CK was elevated. And so now kind of our question is, where do we go from here? So do we switch agents? Do we push through and those kind of things? I think I went through her past medical history in terms of medication. So just to highlight, she was on a statin, which was actually held. And then she was on some serotonergic agents, which will come up as we move along, Remeron and Prozac. And so allergies, really none. So in terms of social history, I'm an ID doc. I love social history, but my focus now is, okay, what's their access and where are they? So this patient's at an acute rehab. So that being said, I have a physician or another type of provider who's going to see that patient pretty regularly. Nursing is, used to having patients on IV antibiotics. When we look at her lab, so kind of at presentation, this is just showing she definitely has an infection. She did have an AKI with her creatinine of 1.76. Sorry for that typo, that CRP 134. 2 weeks into her course, which is where we are now, with the patient being on dapto and ceftriaxone. The only notable thing really is that her creatinine kinase, or her CK, is elevated. It's 422. Her kidney number is normal, liver function panel normal. Her CRP, which we monitor, has dramatically already improved. And just scrolling down a little bit more, this just again kind of reiterates the diagnosis that we already have for OPAT. And now we're just looking more at adverse reactions while on IV antibiotics. So again, our questions are, okay, so the patient is asymptomatic with a CK elevation in the outpatient setting. What do we do? So as I had mentioned, the patient had been switched from Vanc to daptomycin as an OPAT intervention. We have some criteria that kind of flags patients for us to switch. If you ask me who should be switched, I say everyone, unless they have a reason not to be on daptomycin. So things like a pneumonia or CNS meningitis infection. That's really because it's so much easier. Daptomycin is an IV push, which patients prefer. The labs can be drawn at any time, whereas when you're talking about Vanc, you have to do the labs based on your next dosing. There is some literature out there that Vanc patients tend to lose their access a little bit easier. So for this patient, what we were trying to do is adjust her antibiotics, with the other caveat being that she was going to be discharged from Encompass or acute rehab in just a couple of days. So that was one other kind of notable factor. What we decided to do was hold the patient's daptomycin for 2 days. And then repeat CK on day 3. And if that value is normal, consider restarting. We have a great relationship with this particular rehab. The physician and pharmacists there were on board, but they were a little bit skeptical. When we had the patient hold the daptomycin, they did repeat the creatinine kinase. The next day it was up to 1,000 plus. They called us back and said, all right, what are we doing now? And we just said, hold tight, hold another dose. They did that. The next day it was 330, so still elevated. They called us back and we said, just bear with us, just one more dose. And then the following day it was 90, so back in the normal range. At this point, the patient was restarted on daptomycin. She was discharged actually to a nursing home. We continued to monitor her labs while there, and she completed her planned 6-week course with no issues or CK elevations moving forward. Now, that was one example where we have kind of set OPAT intervention in these patients with CK elevations, where we'll try a brief hold if they're asymptomatic. This was started mostly looking at patients who are at home, where it does take a couple of days often to switch an agent. Is there a way that we could maybe get by this and continue the agent that the patient already has at home that is tolerating well? Questions or comments?
Curious as to how others would approach this scenario.
Sure.
Don't be shy. Go ahead and unmute or put your information in the chat. That's called the echo pause. We're not just frozen here. We're letting everybody marinate on it a little bit. So please, the discussion is what's going to help move the session forward.
It's interesting. I think in the ID field, we're beginning to recognize that holding antimicrobials that are causing asymptomatic toxicities and then restarting them actually tends to work very well. And there's tons of literature on that from TB, where your TB drugs that cause a transient or mild hepatitis can be monitored or helped in a similar way. So
Yeah, so if you'd like, I'll kind of move on to another case that exemplifies this point, if you don't mind bringing it up, Jay.
Is that the right one? The one you're seeing?
Yes, yep.
Okay.
So on to the next case. So this patient was a 46-year-old male who had had a rough couple months, had been diagnosed with necrotizing pancreatitis, had an SMV thrombus, which resulted in ascites and issues with spontaneous bacterial peritonitis. At this point, when we were seeing him, it was unknown what was causing his pancreatitis, but he had actually come into the hospital with abdominal pain, diagnosed with SBP, started on ceftriaxone, was doing well, but then had new fevers while in the hospital. At that point, so blood cultures were repeated. He had was found to have Enterococcus in his blood, and also identified to have a right upper extremity DVT. So given that, the consulting ID doc said, I'd like to go a little bit longer than a typical 2-week bacteremic course. Let's plan for 4 to 6 weeks and we'll start daptomycin. Again, kind of just reviewing his past medical surgical history. So some risk factors in terms of issues to have CK elevation once he moved forward. So we do know that patients who have CK elevation are often male, often have obesity. Other risk factors are things like kidney disease underlying. And then sometimes statin therapy, which I won't get too much into because I know Drew is dying to talk about it, or maybe he's not a much. He, as compared to our last patient, this patient is home with home health. He's administering his own antibiotics through a PICC line that was placed and getting weekly labs with home health. And what kind of happened was 2 weeks into his course, he gave OPAT a call and said, I don't know what's going on, but something is not right. I feel terrible. So kind of scrolling down, as Jay said, some of this information is just, again, kind of reiterating how he was diagnosed with Enterococcus bacteremia, which is definitely not in question here. We see his labs when he first went into the hospital, again, just showing us signs that he has an infection with his elevated CRP of 122. His CK at that time was 11. And then about 2 to 3 weeks into course, when he was calling me, the labs from the day before had actually shown that he had a normal CK. It was 182. And his CRP was 11, which is really close to normal on our scale of less than 8. When I spoke with him, he said, I'm not having any fevers or chills. My line is functioning well. I feel like I was hit by a bus. I don't think my home health PT can explain this. The symptoms I'm having, my muscles just ache terribly. I went through that. His labs were okay. His CK was normal, but we're more than a couple weeks into his bacteremic course. Just go ahead and hold it. Home health will come out tomorrow and repeat your labs, and let's kind of see how you do at that point. So once those were resulted, his CK actually jumped up pretty significantly. It was 3,000. I've seen this multiple times before, where you have this CK that is normal, almost low, and then a CK that's not flagged as elevated, but much higher than previous. You can almost bet that the next one's going to be in the thousands, especially if the patient is endorsing symptoms. So what's different about this patient? So now I have a patient at home with a CK of 3,000. His creatinine was normal. His AST, ALT, his liver enzymes were just very mildly elevated. What we talked about was, okay, you're a symptomatic CK elevation. At this point, that brief hold may not be in your best interest, because what do I do if, you know, this occurs again? When you look at the recommendations from the manufacturer too, it says, you know, if a patient's symptomatic, don't retry. We stopped his daptomycin and put him on linezolid to finish his course. Some may say, if they looked at his medication list, he did have Prozac listed, so that serotonergic serotonin syndrome interaction. We talked through symptoms to monitor closely for. He did well on linezolid. Follow-up labs were back to baseline, got his PICC line removed, and his entire adverse reaction to daptomycin was taken care of outside of the hospital.
Again, curious as to if others would do anything differently.
Don't make us call on people. We've done it before. I'm looking at you, John, and Angie, the Echo veterans. I mean, don't, you know, Raymond, everybody on here.
Maybe start bank and state. Dr. Johnson's made it very clear that
No,
that's
yeah.
not what she would
Yeah.
do.
Yeah, yeah.
Yeah, she did it perfectly. Yeah.
We're ready to move to the next case, Jay.
Okay. Hold on 1 second. There we go. Okay, go for it, Joy.
Yeah, can everyone hear me okay? So, I'm Joy, Medical Director again of our COpAT program. This case was taken from Princeton Community Hospital. We have an e-consult partnership with Princeton. So wanted to share a case from our experience. This is a 56-year-old female. The infection type is a bone and joint infection. And she actually had an MRSA right lower extremity hardware associated infection. So which antimicrobial therapy and why? So the proposed regimen to start out is vancomycin and rifampin. Possible transition to linezolid and rifampin, and followed by oral suppression. And the choice here being proposed is Bactrim, because the MRSA isolate had resistant to tetracycline. We would often use doxycycline as an oral suppressive regimen in this case. So for her history of present illness, so when we were consulted, she had been readmitted with a right lower extremity hardware associated infection. She was receiving vancomycin and cefepime. For her medical history, she had a history of coronary artery disease, had prior stenting, diabetes, hypertension, some mental health disorders, and had suffered a closed displaced right tibia shaft, as well as fibula fractures. And approximately 1 month earlier, she had undergone a right tibia open reduction internal fixation with the intramedullary nail. And this was then later followed by right tibial hardware removal, IND, and a new intramedullary nail. So essentially hardware exchange. And at the time of surgery, operative cultures grew MRSA. And this is when we were consulted. So as you can see, she has a long medication list. ones I wanted to point out here is at this point she was on aspirin as an antiplatelet agent. She was also on a statin for her coronary artery disease. And then for her mental health disorders, she was on bupropion or Wellbutrin, buspirone, as well as amitriptyline and citalopram. No allergies. And then for social history, we also look a little bit about her home environment. So she lived alone in an apartment. Daughter was involved in her care. Did have a history of smoking, known injection drug use. So in physical exam, she was afebrile. And at this point, she was noted to have purulent drainage from her right lower extremity incision site. So really over the site of her prior fracture, as well as around her ankle or her distal right lower extremity. The sites more proximally looked okay, and some mild erythema. By the time we were consulted, she was walking in the hallway postoperatively. So in presentation, she had a leukocytosis. By the time we were consulted, that had resolved. I have the rest of her labs here. You can see hemoglobin's a little low, platelets were within normal range, and otherwise really unremarkable. There was no available CRP. When she underwent her hardware removal and reimplantation, again, operative cultures through MRSA, I have the susceptibility panel here. So this basically shows that it was susceptible to vancomycin, which was part of her initial regimen, as well as rifampin, resistant to tetracycline, and susceptible to Bactrim. And blood cultures in her case were negative, so did not have a bacteremia. For imaging, I included some images from her fluoroscopy, actually intraoperatively. We didn't have any images for her physical exam, but this just shows the hardware that's clearly in place and inserted in the setting when operative cultures were still positive. So you can see more proximally and then more distally and along that fracture site in the top image, and then more distally again was where she had most of the erythema and purulent drainage. Go back up. Thank you. And she did already have a left upper extremity PIC placed at the time of evaluation. So some questions about this case, is the proposed antimicrobial regimen appropriate? Is early IV to oral antimicrobial transition a possibility? And then are there concerns about drug interaction? So she ended up being treated with, or our proposed regimen was vancomycin and rifampin to complete an initial 2 weeks. So already had her PIC line in place, did initially go home. So this is at Princeton, so without an established OPAT program that did have monitoring. And at that point had planned to transition to linezolid and rifampin for the next 4 weeks, followed by Bactrim oral suppression for 3 months. So the reasoning behind the rifampin was that she does have hardware in place and it can prevent and work when in a setting of hardware infection with biofilm formation and kind of bacteria sticking to the hardware. So that was the reason for adding rifampin. And then again, the oral suppression because the operative cultures were positive. Again, she did live alone, did have significant mental health disorders. When she was discharged, she did have some difficulty with IV as far as some bag spilling and things like that, but overall did okay. Her course is a little bit complicated at the time of transition. So actually at the point where she was going to transition from the OPAT or IV regimen to COpAT, she was readmitted with an acute MI. This time she underwent percutaneous coronary intervention and stenting and needed dual antiplatelet therapy. So was not only now on aspirin, but also on Brilinta, as well as a statin. So we reevaluated the situation with our initial recommendation to continue rifampin for the full duration and stopped rifampin in the setting of acute coronary syndrome, because at this point it would decrease the effectiveness of the Brilinta as well as the statin. And while in many cases we'll monitor for toxicities and even make some adjustments, we thought that acute coronary syndrome took precedence and the risk of using rifampin in this case would outweigh the benefit. So she did complete out her course with linezolid. She opted to hold 2 of her medicines, the amitriptyline and the citalopram, that would have interacted, but was still on the bupropion and the buspirone. And we counseled her as well for signs of serotonin effects. And she did very well on that regimen, was able to complete out her course, and now is finishing her Bactrim oral suppression. And again, choselanazolid, it is an agent with very high 100% bioavailability. We think in this case that transitioning to an oral regimen was appropriate. What questions?
Thoughts on this case from anybody else? How long should we keep her on Bactrim suppression?
So how I approach these, this is Nikki, by the way. So I do a lot of bone and joint infections usually, but it's usually in the context of prosthetic joints. So there we have a little bit more data. We kind of, say things in the 3 to 6 month range. It sort of depends on what's happened with the hardware. So she had hardware exchange, but she still has a fracture. So, and she grew MRSA. So usually if it's a traumatic injury, I'll kind of try and see if I can keep them on it as long as they tolerate it, at least until the fracture heals. So if there is a relapse, they could potentially have definitive hardware removal, but she's already had some non-healing, so she may not. She may end up developing a more chronic non-union, but that's one thing I'll look for is, because if she does have a relapse, can she have more definitive management with hardware removal? But I don't know what you all were thinking.
We planned a 3-month course or a minimum of a 3-month course. She is following up with orthopedics as well.
And I think you bring up a good point. The goal is to have union first, even though it's going to be an infected union, but the bone healing takes precedence over, you won't get rid of this infection until the hardware comes out.
Thank you. Comments? Okay, move on to the
So
second.
what dosage of Bactrim was used out of curiosity?
We use single strength, 1 tab twice a day.
Would you use
What
the
would you
higher
use?
dose? Yeah.
No, for the suppression, the only other question I wanted to raise to the group. So this was tetracycline resistant, correct?
Mhm.
No, it was
It
the
was.
Staph aureus.
Yeah, it was an MRSA tetracycline
Yep.
resistant.
And it's just a question of the group. Does anyone in their clinical practice, when suppression is planned, specifically request doxy or minocycline sensitivities if you're looking for alternative suppression options? There's some data that those are not always tetra and doxy more closely follow each other's resistance patterns for Staph aureus, but minnow being sometimes a tad different. Just throwing out one other potential suppression option if you run into issues.
Thank you.
Thank you.
And are lucky.
Good point. No, you feel
Oh,
lucky.
Okay. So move on to the second case, please. So this is another patient taken from our experience at Princeton Community Hospital. She's a 53-year-old female, again, with a bone and joint infection. This was a acute worsening of a chronic diabetic foot ulcer with underlying fifth metatarsal head osteomyelitis. But proposed regimen for this patient was ertapenem while hospitalized with transition to moxifloxacin on hospital discharge. And the thought process here was that this was a diabetic foot infection in a patient with underlying osteomyelitis, but without any known history of MRSA or Pseudomonas. So a polymicrobial process. This patient was readmitted with a chronic worsening of a chronic diabetic right foot ulcer with underlying fifth metatarsal head osteomyelitis. She presented with right foot pain, erythema, edema, and drainage. And she was receiving vancomycin and Zosyn at the time of we were evaluating her. She had been hospitalized 1 to 2 weeks earlier. Same issue, so a diabetic right foot infection. And CT scan at that time showed a 3-centimeter abscess along the plantar aspect of the distal fifth metatarsal with associated bone erosion involving the fifth metatarsal head. She did undergo diabetic right foot ulcer debridement when operative cultures were negative, and the surgeon didn't think he found any definitive evidence of osteomyelitis intraoperatively, but it was a more superficial debridement. So she received vancomycin and Zosyn that ended up being extended for 3 days post-operatively and then was discharged without any antimicrobial therapy. Her medical history, again, includes diabetes, and hers was actually was well controlled, but complicated with peripheral neuropathy, chronic kidney disease, and right foot wounds. She had previously undergone a right big toe amputation a few years back, hypertension, morbid obesity, and then some mood disorders. Her surgical history, again, prior amputation, but really what was significant, this, debridement about a week earlier, and now she's back in the hospital. So here is her medication list. And again, you can see it includes some psychiatric medications as well as medication for diabetes. You can keep going down. And no allergies, and she lives alone, no history of smoking or drug use. On presentation, she was afebrile, had a diabetic foot plantar ulcer that was fairly deep, looked like a chronic ulcer with some purulent drainage noted. There was some edema or erythema, edema, and warmth present as well in that area, and then some mild skin desquamation on her right foot. And I think some pictures are included a little bit later, or if you want to scroll down. And so this is her plantar foot ulcer. So again, looks like a chronic process. And you can see some drainage on the gauze. And then below is a picture of her foot. It's actually taken a little bit later when there had already been some improvement. There's one more picture, I think, below. So initially there was a little bit of more skin desquamation and erythema, edema. Go back up, please. These are her labs. So again, on presentation, she had very mild leukocytosis. Labs, when we evaluated her, white blood cell count had normalized. Upper limit of normal creatinine, and CRP was elevated at 2.1 milligrams per deciliter. So slightly different scale than we may use or we use here at our hospital. For her microbiology, her blood cultures have been negative, and when she had her IND a week ago, there was no growth. And her imaging, again, she had 2 CT scans, so I already went over the one that she had the previous admission, but had now a repeat CT scan that again showed this, soft tissue wound, inflammatory changes, as well as erosive changes involving the 5th metatarsal head. So highly concerning, consistent with osteomyelitis. And just of note, she had a prior EKG where her QTC was just mildly elevated. And at the time we were consulted, she did not have any central vascular access, just a peripheral IV line. So the questions about this case is the proposed antimicrobial regimen appropriate? Is the proposed antimicrobial regimen curative? As a curative process? Can our antibiotics fix her? And then is there concern about drug toxicity? So again, we chose ertapenem transition to moxifloxacin, a regimen that does provide polymicrobial coverage, but again, doesn't cover for the MRSA or the Pseudomonas because neither had been isolated. And according to some guidelines for diabetic foot infections, as well as there was a sidestep study that was recently published, in a lot of cases, the ertapenem does just as well as something broader like the Zosyn. And then early transition to oral, is appropriate. So moxifloxacin, again, has about 90% bioavailability, and it is a fluoroquinolone that incorporates anaerobic coverage. So it was a simple regimen, once daily dosing that she was able to take. Is this regimen curative? So probably not, right? This is more of a chronic osteomyelitis. So probably regardless of IV versus oral antimicrobials, that wouldn't completely cure the infection. And she actually did have an additional debridement performed. She is now doing well, has completed out a 6-week course of the moxifloxacin. And talking with her, and just her wound had healed after she had been dealing with this for a while, had opted to go to an oral suppression. So she's on doxycycline oral suppression with plan for about 3 months to kind of keep the process under control. But her foot actually looks good and has been able to salvage it. So is there concern for drug toxicity? So the only other thing I wanted to point out here is we were comfortable using a quinolone in the setting of mildly elevated QT or QTC. And, you know, in this patient, I think she did end up having a repeat EKG a couple weeks later, and it showed a pretty stable value. So she did quite well. Any questions or discussion points?
I just have one in terms of your experience with availability of moxifloxacin. So it's not one that I've used a ton, but I think I know that we have it readily available here with our discharge pharmacy, but I was just wondering about like community pharmacies. Do you ever run into issues with maybe community pharmacy doesn't stock it, or so then do you go to an alternative quinolone plus something else for anaerobic coverage, or you know, is it something you have them, you know, see if they can get filled ahead of time, or how do you approach that, or have you found that to be an issue?
We do. We offer levofloxacin and metronidazole as the alternative. So levofloxacin dose at 750 once daily, and the metronidazole 500 twice a day. Community pharmacies have been pretty good. Where we've run into problems is sometimes when they're discharged to facilities like inpatient rehab, skilled nursing facilities that don't have it on formulary, and we usually go with alternative levofloxacin, metronidazole. And of course, in the inpatient setting, it's not on our formulary. It's a great question.
So Drew, do we have enough time for your didactic? I don't want to rush it in all seriousness. So if you think you got time, that's great. Share it. If not, we can, you know, course correct, but I just want to make sure looking at the time.
No, we should have time to get through everything. So I will go ahead and share my screen here.
Jay, we may need your help to share screen.
Oh, saying that as the host, Jay, I can't. Yeah.
Try again.
Try it now.
Perfect. Thank you all.
Looks good.
I'll go ahead and get started. I opted to choose or to talk a little bit about some of the things that were discussed in the cases in depth, and we kind of superficially go over some literature that's been published both more recently and that's been around for a while that talks a little bit about toxicities and drug interactions with these couple of agents that were discussed today. So that's exactly what we're going to do. And the first thing I wanted to jump into was daptomycin. So our first couple of OPAT related cases involved daptomycin. Not going too extensively into its background, but has an extensive gram-positive activity against many Staph aureus isolates and are more resistant enterococci. This is a unique drug that works by a calcium facilitated alteration of cell membrane homeostasis that ultimately results in lysis of the bacterial cell. So it works on bacterial cell component or wall components, but in a bit different way from things like our beta-lactam therapies or even vancomycin. Daptomycin has a number of adverse effects that have been described in literature and clinical trials since it came on the market. One of those involves musculoskeletal toxicity, or as we also saw earlier today, asymptomatic CK elevation. Peripheral neuropathy, hepatotoxicity have also been described. A more concerning but quite rare adverse event is the development of eosinophilic pneumonia, which would have us concerned with resuming or attempting to administer daptomycin to a patient after this is originally diagnosed. And then hypersensitivity reaction, of course, and occasional hematologic abnormalities. I wanted to briefly focus on musculoskeletal toxicity. So this was actually first observed in early animal studies conducted when daptomycin was first being investigated for bringing to the market back in the 1980s. The incidence of CK or CPK, creatinine kinase, is actually found in those earlier studies to be more linked to frequent dosing interval versus a maximum serum concentration or dose. The way they looked at this was in an animal model where they compared once daily dosing versus Q8 dosing, which we don't see ever in clinical practice with daptomycin, and found a higher incidence of elevation of CK and myopathies with the more frequent dosing. So I think a common misconception might be that we stray away, or whenever a higher dose of daptomycin might be indicated, or might be a little hesitant because we're concerned the higher dose could potentially precipitate CK elevations. But what's been observed thus far is that it's likely more related to dosing interval. The reason that's suspected by this is the case. So daptomycin is believed to break down the membrane around muscle cells and cause the release of CK and the myopathies that's described. So a longer dosing interval would allow for the host to repair any damaged muscle cells in the interim versus like a Q8 hour dosing where they're consistently receiving more dose of antibiotic. This is a more recent study that looked at a number of patients who had received about close to 8 mg per kilo dose once daily for bone and joint infection of daptomycin. They looked at all the patients in this particular population that demonstrated a CK elevation. And much like Jess's strategy demonstrated that holding just a single dose of daptomycin actually allowed the patients in all cases to complete their therapy without adjusting the agent. So I'm reinforcing that as a potential option to manage that toxicity. Next, I wanted to briefly touch on linezolid. So we won't go into a similar spectrum of activity. It's a little bit different in that it works on protein synthesis within bacterial cells. A number of adverse effects and interactions have been described in the literature, including serotonergic drug interactions, myelosuppression, particularly thrombocytopenia, peripheral neuropathies, and other neurotoxicities such as optic neurotoxicity, and lactic acidosis. Of note, the neuropathies have been more observed in courses in the months range, so anywhere from 4 to 10 months. So that would mostly be a concern if that agent's used as, say, part of a mycobacterial regimen, not necessarily in our typical 6 to 8 week course for a number of other infectious processes. So interestingly, the reason linezolid has such a concern with serotonergic agents is that it is itself a weak reversible monoamine oxidase inhibitor, which there's a class of drugs where they are used for purposes of psychiatric conditions. Serotonin syndrome, interestingly, wasn't reported in initial clinical trials with linezolid, but rather in post-marketing data that's since been published. I pulled here data from a 2010 analysis that grouped to close to 10,000 patients looked at across a number of studies after it was brought on market, and believed that serotonergic drug interactions occurred in anywhere from 0.2 to about 4% of studied patients. However, for those familiar, ID Week is an annual conference of, where ID specialties will get together and share information. That's what I pulled from here. This was a verbal abstract presented last year's conference. A single center looked at 1,750 of their adult patients who had got at least one dose of linezolid. They saw of that 1,750, close to half were receiving at least one serotonergic agent, and only 2 patients had a clinical diagnosis of serotonin syndrome at any point in time during the follow-up period that was evaluated. Not only that, when looking at established diagnosis criteria for serotonin syndrome upon retrospective review, only 1 actually met that established diagnosis. Again, re-emphasizing that the incidence of this is quite rare, and as evidenced through our OPAT and COpAT programs here at WVU, we've got quite cavalier at continuing or administering linezolid alongside serotonergic agents. Options that you could do to avoid this, again, discontinuing the agents is certainly a possibility, but may not be feasible for many patients. You could reduce the dose of the other serotonergic agents, or hold a couple of those that may not be that may be more concerning than continuing others. The last couple things were, I wanted to talk a bit about fluoroquinolones and their adverse effect profile. So again, this is a drug that works not on the cell wall, but on DNA gyrase that helps prevent a DNA replication. Fluoroquinolones are known for their robust adverse effect profile that can affect a number of different body systems that are shown up there for you. The ones we will focus that I wanted to mention was cardiac toxicity or QT prolongation. It's been reported with varying degrees among this class of antibiotics and can potentially be enhanced when administered a long time. Other QTC prolonging meds. Reports of cardiac events, however, were still rare when this class was more widely used back in the late 90s and early 2000s, where we've now kind of reined in use of fluoroquinolones more for stewardship purposes. So what I wanted to point out, though, was an early 2000s trial that was actually a randomized controlled trial. They administered single doses of 3 different fluoroquinolones to patients, one-time doses, and then measured their QTC interval 24 hours after receiving doses of those 3 fluoroquinolones. What was observed was that prolongation was greatest, or believed to found, or longest in moxifloxacin in this case, whereas levofloxacin and ciprofloxacin were slightly shorter. Of note, the issue with interpreting anything from this particular study is that these were healthy volunteers without any interacting medications. But this is a general principle we use when kind of considering which fluoroquinolone may or may not be more likely to prolong the QTC. The last thing I wanted to touch on very briefly were drug-drug interactions with rifampin. Really just pointing out that because of its inducible activity on CYP450 enzymes, which metabolize a whole host of drugs for other indications that might be used, will result in decreased serum concentrations of interacting medications. So those could be things like we talked about, anticoagulants like warfarin or the DOACs, anticonvulsants, antiplatelet agents like ticagrelor, like Dr. Jeskovich was discussing. But I wanted to again emphasize that if you have the ability to either consult a pharmacist or perform an interaction check on your own, just to ensure that there's an understanding of which medications might be affected by co-administering rifampin. That is all I wanted to share. So if we have a couple of minutes, I could answer any questions on that material. Well, I appreciate you all allowing me to join this first project with the COpAT team here at WVCTSI. I'm looking forward to seeing how this develops in the future.
Thanks, Drew. Really appreciate it. Again, the recording will come out along with the slides for everybody to review. So if there are any other questions that might come up, please feel free to reach out and we'll make sure we get to the right person. We've got about a couple minutes left. Just remember, if there are any issues with the iEcho account stuff, this is all new for everybody, including the Echo team. So we are kind of wading through the waters like you guys are. So please let us know if there are any issues, because we want to report those back and get them remedied by the IT team there. We'll be meeting again in a month. That's on October 10th at noon, same time. So be on the lookout for information on that. And there'll be a recap email following the session here. It'll have all the information as well as a brief session survey. It's a REDCap. It's about 6 or 7 questions, pretty easy to fill out. We would appreciate it if you could take that as well. All right, everybody. I'm going to hit stop record here.